All right. So then what I did is I recorded it and then I uploaded it onto YouTube because the thing for some reason it separated the audio and the video files for whatever reason. So they're I had to go into YouTube to get it done, but it was easy to do. So start with older adults. Question 65. Common changes of aging.
What type of older adults?
All right, and that is chapter 14.
Thank you.
Mhm.
That felt like way shorter than an hour and a half.
It was like an hour. Yeah, it was an hour and a half or so. I know. It was,
It just like flew by.
yeah, well, I think because today's Friday, so I don't know about you guys what your plan is. We're meeting tomorrow with Nicole at 12 on Zoom as well.
Yep.
So I can send you I can send the link again. And hopefully Nicole might have a chance to watch the videos. They're not terribly long.
I think a half hour for both, or a half
Yeah.
hour.
Yeah, well, it's all it lets me record too, and that's the other reason why there's parts to this, because it says you have 10 minutes left of recording, so not right now, but thing. So starting with physiological changes of aging. So there is your strength gets weaker, your taste buds change, skin integrity breaks down, you don't have as much elasticity. I think the best thing is on for us, page 191, there's right there, table 14.1, common physiological changes with adults at a glance. So loss of skin elasticity, with fat loss in extremities, pigmentation changes, your glands atrophy, thinner hair, it turns gray. Respiratory, you have decreased cough reflex, increased chest diameter, and the chest wall is more rigid. Less alveoli, more airway resistance. And cardio, there's thicker blood vessel walls, less elasticity, lower cardiac output, decreased heart muscle fibers, decreased elasticity, calcification, decreased efficiency of the valves, higher blood pressure, less circulation. So basically, I just say just go over that on in the book 191, the table 14.1, because that literally answers the whole question.
Yep.
So I'm not even gonna go over that because it's easy. All right. And then plan nursing interventions related to the physiological, cognitive, and psychosocial changes of aging. So you have to, I don't know what page you'd even be looking at. Addressing health concerns, I guess, maybe. Like there's bullet points on page 197. So general health. So you have to increase, so you have the risk of decreased cognitive and physical health. You've got more risk of pressure injuries. You've got dementias, foodborne illnesses because they can't smell as well and taste as well, so they can't tell when something goes bad. Oral conditions, so like brushing their teeth, they tend to have dentures, teeth fall out, or they can't brush their teeth because of muscular issues or mobility issues.
Here it says for physiological interventions is like encourage primary dental and vision and hearing visits, participation in recommended screening activities indicated by whatever age, so you get your blood pressure regularly checked, mammogram, depression, vision, hearing, bone density, colonoscopy.
Yeah, oh, that's psychosocial. That's cognitive functional changes. These are changes. All right. Let's say also, so like interventions would be if they live in an isolated area, you might want to encourage them to move or have a home care person come and visit them at least once a day to help with bills and cleaning. Education, yeah, bigger print for stuff, audio visual.
Not using high toned things.
I thought
Low.
it was no, because there was a question we got wrong. I got wrong before where it was was it the high tones that go first?
Loss of high frequency
Okay.
tones.
Okay.
I just read.
Okay. Um, and there's also like you want to make sure that their house is safe for them too. Like rugs aren't rolling up. There's not cords everywhere. 66. So annual screenings and tests. Safe environment. You want to make sure you want to watch out for social isolation and depression. Especially because as they get more health issues, they tend to sometimes they don't socialize as much because they feel like, oh, it's so hard for me to get out. I don't want to be inconvenient, or I don't feel like I smell good, look good, feel good. Learning, and then there was large print, speak loud and in low tones. And then there was what else? Okay, general survey to I feel like there was something else in there. I don't know, but and then I think that's it. Psychosocial. What's the psychosocial one is? So retirement, they may feel bored, which can mean that they're just laying around, not doing anything, eating more, which they get more obese that way. So that's a problem. Grab bars also too are things. So not just like making sure stuff's out of the way, getting equipment to help around the house, getting assistive devices, which also kind of covers hearing aids, glasses, stuff too.
Look at that cute couple on page 199 holding hands, staying in shape. They look so cute. This couple enjoys walking. That's the caption.
Hey. Okay. Do you feel good on that, Crystal? Do you need to go through anything else?
No, I'm good. I had, when I was already filling out my study guide, those are the two that I already had done. So okay. I felt good.
Right. Apply clinical judgment when providing care to patients at risk for or with actual impaired skin integrity. I already answered this. Hold on. So let me get back to it. So nope, 72. Was 70. 67. So you want to check and assess their sense perception, how much they can feel something, their mobility, level of consciousness, risk of shearing, friction, moisture of the skin, risk for infection. You clean site differently than the rest of the body, so you want to make sure it's drier, and especially if it's a bony prominence, not rubbing too vigorously. Prevent pressure wounds by. Go ahead.
I lost for like most of that.
Yeah, I couldn't hear you.
Okay. So you, for 67, the skin integrity wound care, what I have is when providing care, you want to assess their sense perception, their mobility, level of consciousness, their risk for shear, friction, and moisture. That was one of the assessments. I forget which one it was.
That part sounds great.
She's speaking every time she speaks.
Oh no! Hold on.
That's quite funny.
Oh no! Is it? I don't know why it keeps breaking out.
I don't know. But I've stayed in really good contact with Crystal.
Okay, so it's just me. All right.
The whole time.
I'll try again. So you want to assess sensory perception, mobility, level of consciousness, risk of shear, friction, and moisture. Which there was that one chart. Was it the Braden scale or was it the Braden scale? For that risk infection. Clean the site. Well, if there is pressure wounds and you clean it differently than you would the rest of the body, because you might not necessarily use soap and water, you might use the hydrochloride to clean or iodide. You want to also prevent pressure injuries, assess nutrition, pad bony prominences, reposition, get supportive surfaces, so like cushions, those air mattress things that they can put on beds.
Oh,
And then they have these things that'll kind of rotate you periodically throughout the night. So they'll inflate and deflate different areas. Also staging a wound, I guess. I don't know if that is a part of the. I don't know if that's part of the applying clinical judgment, but I mean, I guess that's what I think the clinical judgment would be.
Clinical judgment and providing care to a patient at risk. Oh. Okay. I feel good about that.
Okay. And then patient education is 25, create a teaching plan that progresses logically and promotes learning. So you have to, it's about creating a teaching plan. So I guess it's, I guess first you would assess, are they ready and willing and able to learn? And then you assess how much they can learn. So what's their cognitive function? Are they in pain? Do they speak another language? Do we need an interpreter? Are there any learning barriers? Like, can they not read? Can they not see? Can they not hear? And then, okay. And then
there's only one with patient education. Oh.
Yeah.
All
It
right.
says create a teaching plan that progresses logically and promotes learning, though. So
I feel like that's one that you're just gonna have to like
do.
Yep. Work it out. Figure out your problems. Okay. You wanna hit caring for patients with chronic illness? Wasn't it only like 6 pages?
I think so. It was really short.
Yeah, the part we had. Let's see. Oh, I have it.
Do you know what chapter that is?
8.
8.
Yes, it was page 101 to 106.
Thank you.
Well, that's just the pages we had to read for it.
Mm-hmm. Okay. Discuss the characteristics of chronic disease. Chronic disease is a lifelong health problem you're going to have. You're going to have more medical costs. There's going to be symptoms and other issues that are associated with it.
Isn't it a issue that lasts longer than 3 months can be
6 months?
Oh, 6 months?
Yes. Also, I learned if you go and do the ebook online and you're making note cards or anything, like if you go up to where there's the vocabulary section and you click on the word, it'll take you down to the word.
Yes.
Which is nice.
Oh yeah, the highlighted ones, yeah.
Mm-hmm.
Yeah. Okay. Okay.
Okay.
A chronic disease requires ongoing medical care and often limits a person's usual ADLs due to symptoms or self-care activities required to manage the disease. There's additional expenses, more medication, more visits to the doctor. Lifestyle changes. I feel good about that.
Mm-hmm.
The 3 phases of perioperative nursing. Gross. Okay. It's chapter 50. It's chapter 50. Okay. Okay. Why do you go back? I don't want that. Okay. All right. All right.
Okay, what's the discuss the 3 phases of perioperative nursing? It's like pre-surgery, during surgery, after surgery.
Yeah. So pre-op, intra-op, post-op. So pre-op is you getting the patient ready. You get their medical, surgical history. You assess their baselines. What meds do they normally take or need to take? What are their allergies? Get their consent and tell them what's going to happen. And then you start doing patient education to tell them, because that's part of the thing. So you start playing on like what you're going to do promptly upon leaving surgery and what you're going to do long term. But mostly it's right after surgery that you're going to educate them. Time, feelings, you're going to minimize infection. You're going to maintain fluid electrolyte balance, shave, bathe, void, prevent DVTs, document all the care you've done. So if there's anything that they're at risk for, you'd try to take preventative measures. Intra-op is where they're in surgery. There's a circulating nurse who counts and monitors everything. There's a scrub nurse who is the assistant and hands the things. And then there's a surgeon who's doing the surgery and the anesthesiologist. And then ABCs are monitored, counting INOs, positioning, how they need to be positioned. And then post-op there's 3 phases of post-op. There's out of surgery, where they're monitored, assessed, the family's told. That's where the handoff happens, vitals are taken frequently, and then airway, breathing, circulation, return to normal, the GI function, peristalsis. You can start them on ice and then water and then clear liquids. And then stage 2 is where they're stable. They're not as closely monitored. It's where the family can come and visit, monitor vital signs and pain. And you can go home sometimes, but you also might go to stage 3 where there's a longer recovery time. Again, documentation, but where's stage 3? I didn't really find quite a lot on stage 3 of the thing. Postoperative activity recovery no, that's not it. Nursing roles during surgery, pre-anesthesia unit. So phase 1 is, so then postoperative surgery has the immediate postoperative phase, which is phase 1, postoperative. Phase 2 is recovery and ambulatory surgery, so they get you up and walking. That was what I meant to put on there. Up and walking. And then
are we on the next one?
I was still on the 3 phases of perioperative nursing, but we can go to the next one.
No, it's fine.
Okay. And then I want to just pull up the PowerPoint real quick Because I feel like there's more in the post-operative stage that I did not have.
Okay.
All right, hold on. Let me go down. Maybe I got. I don't know. Okay. All right. Oh, and then the risk factors: the sleep apnea, immunity, imbalance of fluids, nausea, vomiting, urinary retention, embolisms.
471.
Yeah. So
Oh.
comorbid conditions that increase the risk of.
Is that like age, prior clots, active or cancer treatment,
Yeah. So
recent surgery, dehydration, known clotting disorders, obesity?
okay. All right.
Is there
Okay.
a spot with comorbid?
Hold on. It was down. So many slides. Hold on. I know there was the thing.
A table?
I don't know if there's a table there.
I found
It's post-operative complications.
increase the risks for post-operative. Diabetes, heart disease, hypertension,
Bleeding disorders,
OSA,
sleep apnea, respiratory infections, renal disease, liver disease, fever, respiratory disease, immunity disease, chronic pain, alcohol and drug abuse.
Yeah.
Okay.
How are you feeling about that?
I feel all right. And again, there's a chart on page 1422 for us in the book, you on your screen. All right.
1421.
Okay. And we did oxygenation already. So you can go back.
Yeah, we can come back to that.
No, we
later.
did that. We did the oxygenation already.
Yeah, I meant for sure.
Yeah. Okay. All right. So we were at 65. So let's do nutrition. So 62, 63, 64. Nutrition is chapter 45.
Perfect. I forgot you wrote it right down on the sheet, so it's right there.
I did. I have to think about it. Not upgrading. I'm not paying you anything, Zoom.
You got T-minus 10 minutes. Perfect.
Yeah, we can do this in 10 minutes. I think it's not anything hard.
That was me. Sorry.
Okay.
You said we're on nutrition?
Yes.
Shoot, hang on, sorry.
This is one of my highlighted chapters. Wait, was it? Hold on. Let me check it out again. No, I'm just kidding. I'm lying to you.
Okay.
Shoot, hang on, sorry. Where the heck is that?
Chapter 45.
Sorry, I'm not finding it on the study guide.
It's in chapter 45. It's question number 62 through 64.
Oh, okay. Sorry.
No problem.
Explain the variance in nutritional requirements throughout the lifespan.
Oh, okay. So this is.
It was
Did you already
60.
get this one?
Yeah, I did the rest of the questions. So when you're a baby, you need like 100. If you're a normal baby, not born prematurely, you need like 100 100 calories per kilogram of body weight per day, whatever that is. And then if you're a neonate, you need 135. And then when you're 1 to 3, you don't need as many calories, but you need more protein and milk. When you're 6 to 12, you need proteins, vitamins A and C. And calorie stays. I don't know. It says because it says calorie, it says decline in energy, but like that doesn't make sense because that's about the time you start growing like crazy, like a bean sprout. Yeah, it says growth rate slows during toddlers years 1 to 3, need fewer kilocalories but increased amount of protein in relation to body weight. School-age children grow at a slower and steadier rate with a gradual decline in energy requirements per unit of body weight. So they do eat more, but you have to watch for fat, sugar, salts.
Do you remember what page this was on?
This is for us. It's 1179. 1178 to 1179. So it's by figure 45.2 nursing knowledge base.
Okay. I gotcha.
Adolescents need more energy, so more calories, more calcium, protein, and B vitamins, B complex vitamins, excuse me. And then young adults don't need as many calories unless you're pregnant. Then you need a lot more protein and a lot more folic acid and calcium. And if you're lactating, you need 500 additional calories a day. Older adults don't need as many calories, but they do need to monitor their vitamin levels and mineral requirements. They also, especially as you get really old, they struggle and have to change their diets, especially if they have difficulty chewing or swallowing. Cheese, eggs, and peanut butter are all good proteins that are soft to chew. Okay. Okay.
Propose how to implement diet counseling and patient teaching in relation to patient expectations.
I guess I'd start with, well, what is your goal? Is your goal to lose weight, or is your goal to slim down your body? Because there's a difference.
The first question is, do they want to? Because if they don't want to, they're not going to.
Yeah. Like, do you want to? And then there's that one trans theoretical change model where it's I forget what the first one is, but then there's the pre-contemplation, contemplation, the action, and the maintenance.
Oh yeah. I always forget about that.
So do they want to make changes is the first question, and then what changes are they willing and able to make? And then you can meet with groups to find local groups to help support you. You can get customized meal plans with a dietitian. You can follow the food guidelines. Is one of the easiest things to do. Images and teach back, so you teach them and then have them teach you what they're supposed to do. Also, their relationship with food is a thing. I didn't think about that, but I was listening to somebody talk, and they talked about, what's your relationship with food? Is it like do you are you the main chef? Is that like one of the things that makes you eat so much more food? Like, is it emotional eating? Also, what have they done to make changes? And then there's also medical interventions too, if all else fails. Okay. So that's how I'd implement diet counseling. Is I'd meet with doctor, talk about what you want, what your goals are, why, what you've done, what you want to do or need help with, what works, what doesn't work.
What the intra-collaborative goals are.
Yeah, working with dietitian, nutritionist, GI, because there are there are some people that digest foods differently and digest some foods better and some foods worse. Not just like intolerances, but there are just some foods that some people digest better than others.
Mm-hmm.
Okay. All right. So we did so that was 63 and 64, how to implement diet counseling and patient teaching. Okay. All right. Let us stop this because we have 2 minutes left, and then I'll make another group. And then
We'll start clinical judgment through evaluation.
Yeah.
53
So yeah, we want to start 53 to
61.
to 61.
Because all those chapters are right next to each other.
All right. Yeah.
All right.
Yeah, 15. All right. So I will start another invite in a minute.
All right. Sounds good.